As Dr. Heiss said, thank you for the plug. I am Kelsi Chesney, for those I didn't get to meet last night, sixth-year resident at Georgetown, currently looking for a fellowship. And we also rotate at Children's National in DC, where I did this work with the team there. Just want to thank you all for having me. I'm really grateful for the opportunity to talk to you and get some of your ideas. Hopefully you'll find this talk interesting and have some things to share with me. I'm going to be talking about the utility of tonsillar manipulation in Chiari decompression surgery. Additionally, I have to thank the American Syringomyelia and Chiari Alliance Project, who awarded some initial funding through the Timothy George Fellowship Award for this pilot study, with the intention to then expand it to a multi-institutional study. As we all know, Chiari malformation is primarily a radiographic diagnosis defined as greater than 5 millimeters below the foramen magnum, which significance was established in 1986. Can be due to various etiologies, including a small posterior fossa, supratentorial pressure, craniocervical instability, craniosynostosis, a number of things. And as mentioned earlier, it affects about 1 to 2% of the normal population, and then approximately a third of those patients will become symptomatic, for which we are exploring those reasons and then be considered for surgical intervention. So there are a number of surgical treatments which vary in levels of invasiveness. Posterior fossa decompression only, just taking the bone off, not opening the dura, is one step. You can do dural splitting techniques or dural opening with or without various grafts, whether that be autologous or synthetic grafts. And then moving forward to tonsillar shrinking, tonsillar resection, and then in cases of persistent tonsillar crowding or CSF outflow obstruction, you have placement of a fourth ventricular stent. That's not even including fusion for craniocervical instability purposes as well. So I think this survey from 2006 of pediatric neurosurgeons nicely displays kind of the split in practices. For cases with a large cervical syrinx, most surgeons agreed that they would go beyond a bone-only decompression and actually open the dura, but there was wide disagreement as to whether to do duroplasty alone, which is highlighted in yellow, or to actually manipulate or coagulate the tonsils as well, which is highlighted in red. And this was true for cases in which patients were asymptomatic with the syrinx, had a headache, or also had neurological deficits. The treatment goals of surgery are to restore CSF outflow dynamics, which we've talked a lot about already, and then at the same time also minimizing complications, minimizing formation of scarring or adhesions that can potentially lead to recurrence. So this image on the left is one of our reoperations at Children's National, in which you can see these dense arachnoid adhesions which are tethering the cerebellar tonsils. And we thought about this problem and looked at this paper from 2016 in which Thickkamp's group looked at all of their reoperations and the reasons for reoperations. And the largest cause for reoperation was often arachnoid adhesions. And this cohort, most of them had had some tonsillar manipulation in their initial surgery. And so the thought that we had was, does this tonsillar manipulation potentially lead to a higher rate of reoperation due to delayed scarring? There are a couple papers that have reported on some differences in patients that had tonsillar manipulation versus not, and they've had various outcomes. This paper from 2016 favored tonsillar coagulation for a lower rate of reoperation. However, they also included bone-only decompressions in that group, and when you pulled those out, then there was actually no significance. This Braga group in 2023 showed improved Syrinx outcomes in the tonsillar manipulation group, which I think is one of the reasons that many people would say that they do it to help improve Syrinx. But they defined Syrinx improvement as greater than 50% reduction in the diameter or length of that Syrinx, which is different than how others may define improvement. This box in the middle reflects a study by Benny Iskandar's group, which found no Syrinx differences between the duroplasty alone group or the tonsillar manipulation group, and that was based on any degree of radiographic improvement within 1 year. And then a systematic review in 2016 by Zhao et al. Showed that there was a higher rate of clinical improvement in pediatric patients specifically for the duroplasty alone group versus when they had some tonsillar manipulation, and a lower rate of adverse events, which I think is, theoretically how we're thinking about it as well, that the less you do intradurally, ideally the lower rate of complications. Because it's a systematic review, there wasn't super granular data on what those adverse events were, but it was significant. And then another meta-analysis, which includes a lot of these papers, showed that there was no differences in these two groups. So again, we looked initially at just our institution to evaluate the risks and benefits of tonsil manipulation in Chiari patients, primarily as it relates to reoperations, and then secondarily looking at surgical complications and symptomatic outcomes. So we looked at all the Chiari surgeries that were performed at Children's National over 26 years, and for all approaches and all etiologies, we had 323 patients. About half of those were bone-only decompressions, 10% duroplasty alone, about a third included some tonsillar coagulation or shrinking, and then 20% with a fourth ventricular stent. So we excluded the stent, excluded the bone-only, and just looked at these duroplasty versus duroplasty with tonsillar manipulation patients, and then just pulled out their first surgery and excluded any revisions. And then also excluding any causes such as craniosynostosis, spina bifida, or tumor, we came up with 105 patients. Defining tonsillar manipulation as any degree of bipolar cauterization that resulted in shrinking of the tonsils based on operative reports. And that left us with 82 patients that had that done, and then 23 that didn't. And then again, looked primarily at reoperations, adverse events, which included any that occurred within the first 60 days of surgery, and then symptomatic outcomes, which is based on the follow-up notes and the surgeon's report. We looked just interestingly to see over 3 different time periods whether there's any change in trends, and there really wasn't. I think it's because we've had mostly the same surgeons at our institution since the early 2000s who are performing a majority of these surgeries. And then in regards to demographics, there were no significant differences between the two groups in regards to age, gender, presence of a syrinx or severity of that syrinx. We looked at cervical, thoracic, and then holocord. And then surgical indications were also equally split across them. The one significant thing we found was that when the tonsillars were herniated greater than 20 millimeters below the foramen magnum, those patients underwent some form of tonsillar manipulation 100% of the time, regardless of who the surgeon was. And I think that's probably because if the tonsils are so significantly herniated that they're trapped within, like underneath the lamina of C2, C3, then you're going to require some shrinking in order to increase CSF outflow without doing a laminectomy, which would then potentially destabilize that patient. As I said, the surgeon preference played a significant role, similar to the survey results in which approach was actually performed. So you can see here that surgeon A and B performed tonsillar manipulation on 100% of their cases, whereas the other surgeons kind of performed a mix. And so we had to think about this as a potential confounder, especially given that surgeon A, who always did tonsillar coagulation, contributed to about 50% of that total cohort, whereas surgeon D, who did both approaches but kind of made a switch in the mid-2000s, contributed to a majority of the duroplasty alone group. And so we just had to think about whether there were any significant findings that could be related to these individual practice patterns as opposed to the actual surgical approach. And so going forward, we included surgeon in most of our multivariate analysis. Intraoperatively, estimated blood loss and length of time of the procedure were similar. There was a difference in the dural graft type related to the surgical approach, which I'll mention later when I'm talking about complications, because dural graft may play into the risk of CSF leak or aseptic meningitis. And so, interestingly, the surgeon who more often performed duroplasty also used an autologous dural graft, and this was independent and significant for both of these factors. In regards to our primary outcome of reoperation, over 49 months of follow-up, there is no significant difference in the reoperation rate between duroplasty alone and the TM group. And the average rate to time to reoperation was about 60 months after the initial surgery, which you may know is longer than our mean follow-up time, so we could be underestimating that. And, the rate of reoperation was small. We only had about 6 patients, so we couldn't really do a significant analysis on other risk factors for reoperation in this study. This is purely anecdotal, again, because we had such small numbers that were reoperated on, but there was a trend towards a shorter time to reoperation in the duroplasty alone group versus the TM group. And my thought process is potentially that early failure may be due to inadequate CSF outflow being restored, and then these late failure groups in the TM group could potentially be due to scarring or adhesions, and I think we'll need some more numbers to try and flesh that out. Also interesting that over time we showed that our reoperation rate decreased. It's unclear whether that's just due to improved surgical technique by these 2 main surgeons who have been here throughout all this time, whether they are better at selecting patients for different approaches, and or whether we just need more follow-up time, because you need at least about 5 years to capture most of these reoperations. In regards to overall complications, there was no significant differences between the two groups. We did see a higher rate of pseudomeningocele in the PFDD group, which, as I mentioned earlier, with the dural graft type, once we did our multivariate analysis, we found that the approach and the surgeon were not associated with that. It was actually just the autologous dural graft that was associated with pseudomeningocele. And then, though we did not do, I don't know what happened here. Though we didn't do early post-op MRIs on all of our patients, there is a study that does show that in patients who had MRI within 9 days of their surgery in which tonsillar coagulation was performed, 100% had some type of cytotoxic edema within those tonsils, and then 75% had overlying hemorrhage, and about a third had some edema outside the margin of the tonsils, which is often associated with neurological deficits. And so while we didn't actually perform any MRIs on asymptomatic patients, I think it questions whether manipulating or coagulating the tonsils is as benign of a maneuver as we take it to be. For symptomatic outcomes, no significant differences across groups. Greater than 70% of patients improved in all groups and all symptoms. And I want to draw your attention particularly to the Syrinx findings. Again, did not differ between the groups, and we defined this as any radiographic improvement within the first year. And though this is not necessarily relevant to our findings because they were equivalent, I think it's interesting to think about how other studies report the Syrinx outcomes. There's been multiple that show with less invasive methods, it'll take longer for the Syrinx to improve, whether that's bone only or duroplasty alone. And so the quicker time to Syrinx regression is with some tonsillar manipulation. And Syrinxes may continue to improve up to 1 to 3 years after surgery. But regardless of that, most symptoms tend to improve long before the Syrinx actually improve on imaging. So I wonder whether we even need to really track the Syrinx improvement or resolution on these studies, or just look at more clinically applicable factors like reoperation and symptom improvement. This was clearly limited by the cohort size, just 105 patients, and so moving forward, we're hoping to gather 10, 11 institutions and all of their retrospective and potentially prospective data to boost those numbers and give us some more granularity. And then defining tonsillar manipulation was really difficult here. It was just a yes or no based on the operative report, but we couldn't really grade the extensive manipulation. There was just one patient who had a resection, so it was all just some level of shrinking, but it's hard to say whether it was just a little bit or a lot. Length of follow-up is something that we'll really need to improve on with our multiple institutions, and then surgeon variability, which we tried to control for. So I think in our single center study with just 105 patients, there's really no significant outcome differences, whether the tonsils are manipulated or not. And when I'm thinking just about the principles of surgery, which is hopefully to perform the most effective surgery that is the least invasive, you should think that if you can get the same outcomes without coagulating the tonsils and theoretically increasing any risk, then you should go ahead and do that. And just thinking about the talks that were happening earlier with, the brain stiffness, brain motion, is it really necessary to decrease the volume of the brain for all of that to happen, or is it just the decompression alone in which all of these changes can take place? However, patients in our study who had significant tonsillar descent were all selected for tonsillar manipulation. We don't have like a cohort to control and see whether that was absolutely necessary, but I think it does clue us into potential factors in which this technique could be useful. We just have to figure out who those patients are and why. So again, we are hoping to expand this to multiple centers, have a retrospective and prospective component, and we're really looking at hoping to collect video. We're starting at our institution and hoping that others would also agree to share just from the time that the dura is open until it's closed, because then we can use AI analysis to help better grade this tonsillar manipulation and decide whether there's any other intraoperative maneuvers that can change outcomes. And I just got to thank everybody at Children's National, especially Dr. Keating, who's just been a wonderful mentor, a leader in Chiari research. And my email is up there in case you're not already involved in the study. You can also email me and I can send you some information. That's it.
Great talk. First of all, please apply to Cornell. Love to have you for here. Still EY. I was thinking about the degree of tonsillar manipulation. You went into your limitations, but I was thinking about my own practice and some of the own, unconscious bias that goes into how you decide to do that, and maybe that the, more significantly affected patients are getting more manipulation. I think less is generally better. I think your intuition is right, but I think in the patients that are sicker or have more brain stem compression or tighter, those are the ones who may end up getting reoperated on either way.
Yeah.
So that's going to be a tough thing to pull out, from a multi-center study, but worth looking at. And then in terms of the AI or looking at the degree of manipulation, just as a point of, learning, the reoperations that I've done and seen tend to be ones where tonsils are scarred together or scarred to the brainstem, like you showed that picture, and really minimizing any peel manipulation between the tonsils or the ventral surface of the tonsils seems to be the key to preventing that. And so you can be very, very aggressive laterally and on the dorsal surface, but as soon as you get in between the tonsils or along the brainstem surface, you're going to run into that unintended sequelae. So I think that's what you're going to find out when you look at those videos. That's a really great idea to look at the actual difference, because there's going to be a huge variation when you look at them.
Yeah, thank you.
I'd say that there's probably a number of people around the country, myself included, that have moved way towards subpeel tonsillar resection, which you could argue has less manipulation in the big picture. The coagulation looks like a bomb went off a lot of times. And then the post-op MRs I've gotten in those patients, there's very little evidence of a lot of tissue trauma, right? So, those need to be separated out. I think that's a big limitation, because you imply that any type of tonsillar manipulation is bad,
right?
And which may not necessarily be the case. It's actually a good thing, but you're resecting, and that's a better way to go than. But you don't know that this study doesn't answer that question because nobody really did. Yeah, I think some video would help. I think also, identifying which patients this ends up being done in or why would also be really helpful. We did simplify a lot of our variables just to make it easier for multiple institutions to join us. But I think potentially looking at tonsillar volume or crowding or other measures at our own institution could help answer that question.
So can you share what changed your practice? Because I've been struggling with that myself, and I think the MRIs look pretty, but I've been hesitant to go down that road. I wonder if other people benefit from why you changed your mind.
I hate redos. You can fix most people for the most part, but like I said, they're obliterated and they're crowded, and you start to manipulate, and you can just kind of tell you're just not doing the job. I tell the patients it's kind of a game-time decision. You get in there, things are really tight, and the only way you can really get the job done is removing the tissue. I immediately switch. So I don't know, other people in the audience probably do it too, but that's my decision tree now.
I just want to mention that what sadly is never really considered is also the arachnoid pathology that we see with the Chiari decompression. When we open, sometimes there's significant arachnoid pathology thickening, and then we have to also be aggressive. So it's not just the tonsils, right? So if you do your prospective study, so it would also be very valuable to, videotype or also mention what we do to the arachnoid. And I'm always worried about when sometimes we have to aggressively resect the arachnoid, which is, really violating this very important layer. And then I always wonder if that also, that causes an arachnoid pathology, arachnoiditis, or immune changes, and that might cause also reobstruction. So I wonder whether any of the studies that you did review had mentioned anything about the arachnoid pathology. In my mind, arachnoid pathology is way more important, as important as tonsil pathology.
Yeah. Some of the studies had a grading system for the arachnoidopathy. Again, it's really hard to pull that out from just operative reports, is how it really looked in there. So I just couldn't include it in ours. But that's why I think video could be a lot more helpful for kind of looking at all of these different variables and not just where tonsils touched your
biomarker to look at.
That's a good question. Just the surgeons in the crowd. This is for the scientists. How many? I've observed this for decades. The tonsillar branch of pica many times moves around the tonsil right over the fourth. It goes right up. And sometimes there's two of them. I did one the other day. Like they're kissing and they're huge in there, and that's got to be part of the obstruction. So you have this arterial flow, one or two pretty good-sized arterioles that are right in the way of the CSF outflow, and that's never been accounted for. I mean, Arnold Menezes wrote a paper one time. He just categorized all the intraoperative findings. I haven't looked at it carefully, but I haven't cataloged it myself. I'll say it's like probably 30% of the time. You never see a normal patient, you know, like a posterior fossa tumor, you know, you never would see that. But the Chiari patients, they're under what
Do you think developmentally because that's just how they route and they develop because there's
I don't know. It's a wild card. It's something that you probably can't model, but it's there, and you don't see it all that often in the MRI. You don't see like a rapid failure forward, which totally changes the CSF flow for sure.
Yeah, and I think additionally also the choroid plexus cyst that you don't see
Yeah.
on MR imaging. You go in there, it's like it's completely obstructing the orthogonal.
Okay, we have a 10-minute break. You have more questions for Kelsi?